In the search of new therapies for the tuberculosis, we are trying to harness the potential of the whole defense peptides for TB therapy. There is a paradigm change where our fight against the tuberculosis is shifted to fix the immune system and not only the bacteria. So we have identified and targeting various factors which are usually hijacked by the pathogens that can be used for the development of nanotherapeutics. These includes the induction or delivery of the whole defense peptides, enhancing antimicrobial mechanism induced by inducing autophagy or apoptosis, induction of the induction and delivery of the pro-inflammatory effector molecules like nitric oxide, reactive oxygen species, and cytokines. Here we have started with the exogenous host defense peptides as the adjunctive therapy for the tuberculosis. The whole defense peptides are the cationic molecules produced by the immune system of the body that has immunomodulatory function and help in the defense mechanism against the pathogen. There are substantial evidences accumulating that whole defense peptides has good antimicrobial activity against the normal as well as the drug-resistant bacteria. And they also have the several advantages over the antibiotics that they are fast-acting antimicrobials, they are effective against the drug-resistant bacterial strains, and moreover, they don't have any cross-reactivity with known anti-TB and anti-HIV drugs. So for our studies, we have selected 13 peptides for which the activity was known in different bacterial strains, but their activity against the TB bacteria was not established. And we thought that they can be potential candidate for the TB therapy. So we synthesized these peptides using the solid phase peptide synthesis method in our lab using the CM peptide synthesizer. And these peptides were purified by the HPLC and verified by the MALDI-TOF. Yeah, we conducted in vitro antimicrobacterial activities with these molecules using the colony forming assay. Here we found that out of these candidates, 4 peptides showed the significant antimicrobacterial activity with the low MIC values. These are coded as in the green color in the table. But there are some severe shortcomings to be used these peptides in therapeutics, as they have the short half-life, they have the cell toxicity, they have the cell sensitivity, they are protease sensitive, and they have the poor pharmacokinetics, and they undergo the first pass metabolism. Hence, it is very difficult to introduce these HDPs or whole defense peptide as such in the biological system in a controlled manner by using the conventional drug delivery system like oral or parenteral delivery system, and to kill the bacilli residing in the alveolar macrophages. It is essential to deliver sufficient amount of whole defense peptide in the lungs and the alveolar macrophages where the bug actually resides. So here we chose inhalation route of administration for the delivery of the whole defense peptides because it have several advantages over the oral or parenteral delivery systems. Like it can bypass first pass metabolism, reduce the systemic side effects, and can have the quick onset of action. Here we developed and evaluated in our work, we have developed and evaluated different inhalable formulations to stabilize the whole defense peptides and make them suitable for the human use. That I will discuss in next few slides. Firstly, we prepared the host defense peptide loaded polymeric PLG nanoparticles for the inhalation delivery and tried to deliver these particles to the animals by the inhalation using the animal inhalation assembly. We estimated the inhaled dose in the animals by the bronchoalveolar lavage using the tracheotomy technique. And in this study, we found that a very low fraction of the formulation got deposited in the lungs of the animals. And we concluded that since the particles are too small in the nano size range, and they have very low density, so most of the formulation got exhaled by the animals during the breathing process. In search of appropriate formulation for the deposition in the lung, we further prepared different. So, uh, we further prepare different types of microparticles with a varied shape, size, porosity, and density. These particles, like golf-like particles, porous microparticles, highly porous density particles, mucus penetrating particles for the better pulmonary delivery. All of the particles were evaluated for the peptide release, mucus penetration, aerodynamic parameters, and alveolar macrophage uptake and stability of the peptide inside the particles. And then we determined the aerodynamic parameters and the pulmonary deposition of the dry powder formulation that was investigated by uh, in vitro cascade impactor. This is the 7-stage cascade impactor. The cascade impactor is the machine that segregates the particles according to the aerodynamic size, and different plates of the cascade impactor mix the different parts of the respiratory tract. And it gives the idea of the fraction of the powder deposited in the each part of the lung. So aerodynamic characteristic was determined by the evaluation of the mass, median aerodynamic diameter, and the fine particle fraction of the microparticles. So the MMAD of 1 to 3 micron and the fine particle fraction more than 40% was found to be appropriate for the inhalation. And we found that the particle size of 1 to 5 micron particle size is ideal for the deposition in the alveolar region of the lungs, where the bacteria resides in the lung. On the basis of aerodynamic parameters, we developed a series of polylactide microspheres for different pore size for tuning the release of the antibiotics, and the peptides for different sizes in the lungs. So microspheres were synthesized by double emulsion solvent evaporation method with a precisely optimized concentration, molar concentration of porogens to generate the pores of various size. The microspheres of 9 different porosities were successfully prepared and investigated in our experiments. So we gained the expertise in tuning the microparticles for different pore size. Out of these porous nanoparticles, microparticle with around 13 nanometer demonstrated the optimum release kinetics of the peptides, and hence it was used in our studies. We use these microparticles for developing individual inhalable formulation for 3 peptides that were UB2, K4, and Orin 1.2. They were active against the Mycobacterium tuberculosis. This formulation demonstrated killing of bacteria by the membrane disruption after the release from the particles, and hence enhanced the permeation of anti-TB drug, which was administered simultaneously. The direct interaction of the host defense peptide with the virulent S37 RB TB bacteria led to the pore formation and the membrane lysis of the bacterial cell wall. It was able to penetrate a strong mycolic acid layer, which led the permeation of the bacterial membrane. As you can see in the electron microscopy and the atomic force microscopy images, that shows the morphological changes in the cell wall after the interaction with the HDP. And it included the blebbing, corrugation, and intracellular leakage, which was ultimately led the bacterial death. The in vitro antimycobacterial studies were conducted by using colony forming assay. Here, the treatment of TB bacteria with different concentrations of pure and encapsulated host defense peptides demonstrated the killing of TB bacteria in dose and time dependent manner at the micromolar concentrations of the peptides. The microencapsulated peptides demonstrated significantly higher efficacy against the TB bacteria compared to the pure peptides. And the effectiveness of the UB2 peptide was most promising, followed by the K4, and then Orin 1.2 peptide. All three peptides showed additive effect with a half dose of anti-TB antibiotic against the Mycobacterium tuberculosis. And this shown additive effect of HDP could be substantially decrease the concentration of the conventional antibiotic in the therapy. In these studies, we realized that the higher dose of the HDP or whole defense peptide can be toxic to the human cells. When we treated TB bacteria with this low sublethal dose of whole defense peptide, along with standard anti-TB drug, it enhanced the permeation and accumulation of anti-TB drug into TB bacteria by more than 4.8 times. It enhanced the killing of the bacteria. And this estimation was done by the LCMS. Further, we prepared more improved formulation in the form of hybrid nano and micro assemblies with the aim to improve the aerodynamic parameters and the pulmonary deposition of drug or peptide in the lungs. One formulation was the nano and micro drug delivery platform, and other was the porous nanoparticle aggregates. For a nano and micro drug delivery platform, peptide loaded nanoparticles were suspension was freeze dried using the DPPC lipid into the liquid nitrogen using the spray drying system. It generates the particle where the lipid form the coating over a bunch of nanoparticles and to form the micron size nano and micro system. These particles look like a beautiful bird nest having the egg inside. And the PNAPs were prepared by the spray freeze drying of the nanoparticle suspension in the presence of the mannitol sugar. These we showed the mulberry shaped microparticles. The nano assemblies are supposed to disperse in the pulmonary drug loaded nanoparticles from the aggregates as soon as they deliver into the lung and cover more area in the lung as compared to the conventional microparticles to improve the better pulmonary delivery and impart better efficacy. The formulation of porous nanoparticle aggregates with the peptide was prepared using the spray freeze drying technique, where we used the new peptide that was meguanine 1 analog peptide, which showed the very nice activity against Mycobacterium tuberculosis with low MIC. This was used as a model drug in this formulation. The MIP loaded nanoparticles were prepared by a double emulsion solvent evaporation method, which were around 300 nanometer, which was further processed into micron size PNAPs. The PNAPs demonstrated sustained release of the peptide for 8 days in the released medium that mimics the lung and found to be stable during the release period. This was estimated using the CD circular dichroism. And all the formulation were more efficiently taken by the macrophages cell line as compared to the conventional microparticles. The in vitro anti-TB activity of the MIP and its formulation was assessed against virulent TB bacteria. For this, macrophages were infected with the tuberculosis bacteria, then treated with a different concentration of the pure and encapsulated peptide for 3 different intervals. These results were compared with the standard anti-TB drug. The peptide in solution showed the bacterial killing at higher concentration, while the encapsulated peptide demonstrated dose-dependent killing at all doses we used in this therapy in this experiment. The peptide showed synergistic enhancement of the bactericidal activity with the anti-TB drug. Further, we did some molecular mechanism elucidation, and here we did this phagosome maturation studies because the TB bacteria is an intelligent bacteria and intelligent and successful bacteria, which is capable of inhibiting phagosome maturation for its own survival. So this formulation found to revert this phenomena to kill the bacteria. When the Mycobacterium tuberculosis infected macrophages were treated with the whole defense peptides containing formulation, it enhanced the phagosome fusion to kill the bacteria. Here, the yellow staining at of the lysosome showed the phagosome lysosome maturation and the bacterial killing. In the course of studies to improve inhalable formulation, we realized that tuberculosis pathogenesis, in the tuberculosis pathogenesis, there are several barriers. Bacteria forms the biofilm, and the lung produce the mucus, which together form a barrier that impedes the penetration and the activity of the antibiotics and their formulation against the TB bacteria. Hence, and it contributes to the development of the drug resistance. To tackle this problem, we developed a new inhalable mucus penetrating microparticles. It contained the combination of the whole defense peptide and a standard anti-TB drug that was isoniazid in the polymer PLGA microparticles. Then these particles were coated with the mucus penetrating agents. And these particles are not supposed to adhere with the mucus and provide the uniform and are supposed to provide the uniform distribution in the airways after the pulmonary delivery. The electron microscopy image of uncoated PLGA particles shows a smooth surface, while the NAC, that is N-acetylcysteine, coated, that is the mucus penetrating agent, coated particles showed the rough coated surface. The particle size of these particles were around 5 to 6 micron. And this particle shows appropriate parameter for the inhalation with the aerodynamic diameter of around 3 micron. And it was optimized for the finest deposition and the targeting inside the lung. The mucus penetration studies were carried out by the multiple particle tracking technique and transwell diffusion method. Where the porcine mucus was treated with the mucus penetrating agent, that is N-acetylcysteine, and it decreased the viscosity and changed the microstructure morphology, which further enhanced the diffusion of particles through the mucus. In the mucus meshwork architecture, the size of the pores increased after treatment of NAC, that is N-acetylcysteine. In the MPT, that is multiple particle tracking studies, NAC coated particles, that was mucus penetrating particles, demonstrated more particle displacement in the mucus as compared to the normal PLGA particle. And the similar results were obtained within the transwell diffusion cell method, where the NAC, that is where the NAC coated N-acetylcysteine coated particles demonstrated more particle displacement and enhanced penetration through the mucus layer as compared to the normal PLGA particles. So they are more appropriate in the case of the tuberculosis where there is a lot of mucus in the lung. And then we did the biofilm disruption studies, which were conducted against the Mycobacterium biofilm using the crystal violet method. This formulation demonstrated and sorry, this is the slide. Conducted against the Mycobacterium biofilm using the crystal violet method. And this formulation demonstrated anti-film activity against the TB bacteria by the biofilm disruption in the dose-dependent manner in 3-week biofilm culture medium. The blue color in the slide shows the formation of the biofilm, and the yellow color shows the disruption of the biofilms in the Petri plates. And this formulation was then evaluated for the macrophage uptake viability studies and in vitro efficacy studies against the virulent intercellular bacteria. The formulation demonstrated the efficient cell uptake in the macrophages. It did not show any apparent change in the viability of cells after treatment with 10 to 100 micron range concentration, where it shows the dose-dependent killing of mycobacterium in the infected macrophages. In the CFUSA, after that we did the animal trials. After that, we did the animal trials where the mice were infected with the virulent TB bacteria by the inhalation route using Glasgow inhalation apparatus, which established the tuberculosis infection in 3 weeks. And then we treated these animals with a different inhalation dosing of microspheres, which were compared with the oral dosing of anti-TB, standard anti-TB drug as a positive control for 3 weeks. And treatment efficacy of normal microparticles and mucus penetrating particles were also compared in this experiment. After 6 weeks of dosing the After 6 weeks of dosing, lung morphology of the untreated and the blank treated blank treated animals showed the nodules on the surface. These nodules you can see in the yellow arrows in the slides, and shows the nodule on the surface of the lungs, which were healed after the treatment of the mucus penetrating particles and the normal particles in the dose dependent manner. Both of the formulation showed the efficacy in the inhalation after the inhalation, and similar healing was observed in the positive control. That was the oral standard anti-TB drug. That was the isoniazid and the rifampicin combination. And there was the complete healing in the lung. Similarly, if you see this histopathology, the granular formation appeared in the histopathology of untreated lung, and which was disappeared at the higher dosing of the microparticle dosing. The inhalation of the HDP loaded mucus penetrating spheres significantly healed the lungs. And but in the morphology, if you see in the lung morphology, the nodules completely disappeared after 1.5 months of treatment with the inhalation of mucus penetrating and the normal microparticles. But these dispersed the granulomas in the histopathology. There was not complete healing, but there was the reduction in the CFUs in the lungs. The colony forming assay of the tissue homogenate in the lung of treated animals demonstrated that the inhalation of HDP loaded mucus penetrating microparticles significantly reduced the infection level of in virulent TB infected lungs of mice. The efficacy of the mucus penetrating particles were higher as compared to the normal particles. The combination of whole defense peptide with the half dose of standard anti-TB drug shows the additive effect and showed the complete clearance of the bacteria from the lungs. So I will conclude my talk with the conclusion that the whole defense peptides are efficacious against the virulent TB bacteria, and the combination of low dose or sublethal dose of whole defense peptide increases the antibiotic uptake in TB bacteria by more than 4 times. And it demonstrated strong anti-biofilm activity. And after daily inhalation treatment with HDP formulation, it led to treatment of the tuberculosis and the healing of the lungs in 1.5 months. And we currently are working on their pharmacokinetics and biodistribution studies and the toxicological studies. And I believe that these have potential to be utilized as adjunct post-directed therapy with the conventional dot therapy. So I'm thankful to my institute for providing me the necessary facilities and the constructive research environment. I would like to acknowledge my collaborator, Dr. Amit Singh of Jalma Institute of Microbacterial Disease for providing the animal BSL-3 facility for virulent experiments. I would like to acknowledge my students for this work. And I am thankful for the funding agencies like DST, Nanomission, and ICMR for providing the funding uh, for this research. Thank you, and questions and suggestions are invited.
Thank you, Dr. Rahul, for such an enriching talk. It was very informative, and I'm sure it was very fruitful for us and our audience. So, okay, so let me ask a few questions. So what is the main things means in the drug control releasing aspect? So what are the time window here we are getting if we are using the nasal inhalation, especially in the lung? So there are a few aspects means it's come up the pathogen is increases and then involved into the pathogenesis and showing the some kind of infiltration of the immune cells. So what are the time window we can get if we do the inhalation of these nanoparticles?
In case of inhalation, we have optimized the time window of 5 to 8 days for the release kinetics of the drugs, either the drug or the peptides or any other biomolecules. Because when we did the when we treated the animals with the particles or the formulation having the control release kinetics for 5 to 8 days, then we found the complete clearance of the bacteria in the time to time. Like after 10 days or 15 days, we found the complete clearance from the lungs.
Okay. And how much means what's the drug concentration we can get that localized area?
Yeah, it depends upon the disease. Actually, in the case of tuberculosis, we need the high dose. Actually.
Okay.
We know that we need at least 3 to 4 mg of drug to the lung for single dose.
Okay. And especially for the means, if we talk about the drug as well as the encapsulation, the triggering point is the target delivery. So in the macrophage or other immune cells, I saw that you are using the NAC for the delivery of for the mucus membrane therapy. So did you try for the specific macrophage receptors like Fc gamma R receptors or some kind of the receptors coating on the nanoparticles so that it can target it specifically the specific immune cells and maybe they involve in different type of phenotypic and functional responses?
No, we have not yet targeted any targeting moiety because we found that these particles were already efficiently taken by the macrophages in the lung. As we did the bronchoalveolar lavage in the animals after the inhalation of the microparticles, we found that there was the efficient uptake of the particles in the cells. So we didn't try this moieties.
Okay, and is there any suggestion, is any alteration into the function of these cells with only the nanoparticles without drug? Is any functional responses is altered with this treatment?
Yeah, we found there was a decrease in the pro-inflammatory cytokines after the treatment.
Okay. Okay, thank you, Dr. Rahul. So I would like to open this session for some other questions. So let me see. Dr. Santos, you want? So there is a question, did you use the propellants? If yes, so which kind of propellants did you use?
Actually, we didn't use any propellant. We are working on the dry powder inhaler that we only need the lactose as the excipient for the inhalation delivery in the DPI. We don't need any propellant. Propellant are used in meter dose. So we are just working in dry powder inhalations.
Okay. And regarding inflammation, you already covered. Okay. Okay, thank you so much, Dr. Rahul. It's very informative presentations. Thank you.
Thank you, Dr. Alok.
So the next speaker is the Dr. Vinod Tiwari, and I would like to request Dr. Santosh, please introduce our next speaker. Dr. Santosh, over to you.
Sure. So our next speaker is Dr. Vinod Tiwari, and he's a presenter working as an assistant professor of pharmacology in the Department of Pharmaceuticals, Engineering and Technology from IIT BHU. And he has been working as he did his PhD from Punjab University, Chandigarh in 2012.
Okay.
It's equal. So he did his PhD in 2012 from Punjab University, Chandigarh, and post PhD he has been continuing as a postdoctoral research from Johns Hopkins University, Baltimore, Maryland. So before joining IIT BHU, he has been working as an assistant professor at NIPER, Ahmedabad from 2016 to 2018. So Dr. Tiwari is working in the field of pharmacology and neurosciences for the past more than 15 years, and his research interest is focused on behavioral and the molecular neurosciences dedicated to understand the various neurodegenerative disorders and the signaling pathways involved so that the better and the safer drug candidates can be developed by targeting the disrupted neuromachinery. And during his PhD, PhD and postdocs, he has published more than 51 research publications with more than 14 review articles and 4 books and chapters in the peer high impact journals with contribution like say Nature Neurosciences, PNAS, JCI, and many more. So with this brief introduction, I would invite Dr. Tiwari. Over to you, Dr. Tiwari.
Thank you so much, Dr. Santosh, for the nice introduction. I would like to thank Dr. Alok for providing me this opportunity to speak in this meeting. So it is, really a pleasure to, attend this event. So yeah. So I will share my presentation with you so that. Hope I am audible to everybody. Am I audible?
Yes, yes.
Okay, good. Hope the screen is visible, right?
Yes, no, it's clear.
Yeah.
Okay, great. So thank you once again. So yeah, I will request audience, if they have any questions in between, feel free to interrupt me and ask any questions. Okay. So topic of my today's talk is mu delta opioid heterodimers, which we feel are potential targets for the treatment of neuropathic pain. I have been working in the field of neuroscience, especially neuropathic pain, from past more than 15 years. So we were exploring different aspects of the neuropathic pain, like how we can treat this, like one of the devastating disorder, I would say, because it affects the quality of life, and the treatment which we have in the clinic, they lead to so many side effects. So we are, trying to develop some new molecules or formulations which can treat the neuropathic pain and its different dimensions, and at the same time can help in relieving the toxicities associated with the current therapeutics. Okay. So before starting my talk, first of all, I would like to pay my tribute to Pandit, Mahamana Pandit Madan Mohan Malviya, who is, the founder of this beautiful temple of learning where I belong to, Banaras Hindu University. So on the left-hand side, you are seeing is the postage stamp, which Government of India recently launched, on completion of the centenary, 100 years of the BHU. So we recently completed 100 years in 2016. Okay, so the first and very obvious question which can come to any new mind, whether pain is good or bad. So many of you would say that it can never be good, it should be bad, right? That's why we are trying to treat it, right? So there is a small, quote I would like to share with all of you. Oh man, you curse me, blame me, you hate me and frown at me. You think I am cruel and heartless. You try to slay me with anesthetics, with chloroform and bromides. You attack me with sedatives and opiates. You phone the doctors, you run to the hospitals, you fly to Vienna and hill stations, you wire to your friends and relatives, you approach the sands of the Himalayas for remedies and herbs. You do Mahamrityunjaya Japa and Havana. You burn incense and pray to kill the teacher who wants you, who comes to help and bless you. I'm not your enemy, I'm your friend. I'm your guide and a silent teacher. I'm pain, the best thing in this world. So with this, I would like to, sensitize the audience, that pain is not always bad. It is a protective mechanism of our body, which acts as a warning signal, which tells us that something wrong is going on in our system, and that is supposed to be taken care of immediately before it becomes chronic in nature. So definitely chronic pain is never good. If somebody is suffering from nerve injury induced pain, such as back pain, there is migraine, arthritic pain, or any other kind of pain which is chronic in nature, that is not good and that needs immediate treatment. Okay, but acute pain is always important. Yeah. So according to IASP, which is International Association for the Study of Pain, pain is an unpleasant, we always call it unpleasant, it can never be a pleasant thing, right? It is an unpleasant sensory and emotional experience. I'm trying to emphasize that it is a sensory and emotional experience. Sensory because we can feel it, right, when there is any kind of stimuli, right? And it has different dimensions. Pain has sensory component, at the same time it also has affective component, which affects our whole psychology, the way the patient work and deals with his daily life routine, right? It affects the CNS neurocircuitries. The patients who are suffering from chronic pain, they are more prone to suffer from other CNS etiologies as well, such as depression, anxiety, and even cognitive dysfunction. So it has a lot of effects on the quality of life of patient. And according to ISP, it is an unpleasant sensory and emotional experience which is associated with or resembling that associated with actual or potential tissue damage. So this is the definition of pain, which was recently revised by Professor Srinivasa and Raja and his colleagues, in 2020 only. From past 30 years, there was another definition which was slightly different from this definition. So I was associated with Dr. Raja during my postdoctoral research in Johns Hopkins. So when it comes to like how do we feel this pain? So nature has given us a wonderful gift. For example, we can taste different kind of foods. We have the receptors for that, right? We can sense different kind of we can smell different kind of like smells, right? In the similar manner, nature has given us a wonderful gift in terms of different nociceptors, which can sense different kind of pain sensation. At the same time, our body also have the receptors to distinguish between the different kind of touch versus pain sensation. Okay, so I'm not going to into that dimension of, like, because my talk is mostly associated with the pain. So if I talk about the thermal pain, for example, when you hold a hot cup of tea or coffee, or for example, when you take a shower with the hot water, right? How do you feel that it is hot? And how do you decide that what temperatures is optimum for your body while taking a shower, right? So we have thermoreceptive nociceptor, for example, TRPV1, which we also call as capsaicin receptor, mirch, right? Everybody knows mirch, right? So whenever we eat the capsaicin, we have that burning kind of sensation in our mouth, right? So that burning kind of sensation is because of the activation of TRPV1 nociceptor. At the same time, when we eat, when we take menthol, right, we have the cold sensation in our mouth and the tongue. So that cold sensation is attributed to the activation of TRPM8 receptors present in our mouth and tongue. In the similar manner, we do have other kind of nociceptors, for example, mechanoreceptive nociceptor, which can actually detect the mechanical stimuli. For example, when we, when somebody is getting stimulated with some injury, mechanical injury, right? So the example is MRGD receptor, mass-related G protein coupled receptor, right? So Professor Shin Jung Dong, who was my collaborator as well in Johns Hopkins, he's working in this area from past several years. Now there is another nociceptor, TRPA1, which is transient receptor potential anchoring 1 receptor.
So looks like there's some network issue. We are trying to get in touch with the speaker.
I'm really sorry about it. There was some network issue on my end, so I'm really sorry about it. So
That's okay. Dr. Vinod, you can share your
yes.
slides.
Yes.
And I will tell you which. Yes, this is the same slides.
So I'm really sorry for the interruption due to network issue. Okay, so in this slide, what I'm trying to actually talk is about the nociceptive transmission from the peripheral nervous system to the central nervous system, right? I hope I am audible to everybody, right?
Yes, yes.
Okay. Second. Okay. So yeah, so whenever we have any tissue injury, we do have the nociceptors which are present in the peripheral nerve terminals, and they are activated in response to the tissue injury. And this information from the peripheral tissues get transferred to the primary sensory neurons, which are the dorsal root ganglionic neurons present just before the spinal cord. And once this pain information reaches to the DRG neurons, it gets transferred to the spinal cord. So spinal cord acts as a relay center where this pain information gets modulated before it gets transferred to the higher centers present in the brain. And that is how we feel the pain. And all these, things happens within fraction of milliseconds. Okay. So if we talk about the symptoms of pain, we generally, talk about mechanical allodynia, which is a enhanced pain sensation due to non-noxious stimuli. For example, the patients who are suffering from diabetic neuropathy or some other kind of chronic neuropathic pain, the patient, they do feel pain even when they wear their shirts or socks. So wearing shirt and wearing socks is not a painful stimuli, right? It is a very normal thing, right? But still the patients feel the pain. So this term is known as the allodynia, which is enhanced pain sensation due to non-noxious stimuli. But whenever there is enhanced pain sensation, when less noxious stimuli becomes more noxious in nature, that we call as hyperalgesia. So if it is due to any mechanical stimuli, we call it mechanical. And if it is due to temperature changes, we call it thermal hyperalgesia. Okay, now in this slide, I'm trying to share with you the different causes of neuropathic pain so that I can, convince you that neuropathic pain or the pain is not only a symptom, it is actually a disease which is supposed to be treated well. So for example, exposure to certain drugs, for example, chemotherapeutic agents are there, other toxic drugs are there, which lead to the nerve injury and leads to the pain sensation, sometimes chronic pain. Alcohol, we all know that chronic alcohol consumption led to the hepatotoxicity, right? But very few of us know that if a patient is, if a person is consuming alcohol for a prolonged period of time, it not only hurts its liver, but it also hurts its nerves and lead to the peripheral neuropathy. Now, due to traumatic nerve compression, nerve injury, also sometimes a person may, end up damaging its, nerves and lead to neuropathic pain. Some viral infections are there, such as HIV infection, which also lead damages to the neurons and nerves and leading to HIV-associated neuropathy. Some vascular-related neurodegenerative disorders are there. For example, diabetes and metabolic nutritional deficiencies such as vitamin B1, which is a very important constituent of the myelin sheet. So in the absence of vitamin B1, myelin sheet cannot protect itself against the variety of due to oxidative stress, enhanced inflammation, all those issues. Sometimes due to cancer, you might have heard about the bone cancer pain, which is one of the most severe pain, I would say. And the patients who are suffering from this, they need proper care. Sometimes due to surgical procedures, for example, when the soldiers, they are like in the battlefield, they are undergoing through the stressful conditions such as at high altitudes, very cold, right? So there they suffer from the gangrene. So the doctor doesn't have any choice but to amputate the organ, the extremities of the patient. So during amputation, there are damages to the nerves, which leads to the long-term chronic pain in these people. So these are some of the incidences which I wanted to share with you and trying to convince you that it is a disease, not only a symptom. Okay. Am I visible to all of you? I doubt.
Your slide is visible. It's okay.
Okay. 1 second. I don't know what is the problem. Like why? What is the problem? Okay. I hope now I'm visible. Okay, good. Okay. Okay. So that's why I'm trying to emphasize that neuropathic pain is a common pain state that needs better therapy. If we talk about the prevalence of the neuropathic pain, 7% of the general population and 18 to 21% of the patients who are treated in pain clinics, they belong to the category of neuropathic pain. If we talk about the impact of this disorder, it poses a huge social and economic burden on the society, and it adds to the high healthcare cost and lost productivity to the any nation. If we talk about the treatment which we have available in the clinic these days, I would say it is really difficult, and the analgesics which we have in the clinic, they produce inadequate pain relief. Only less than 50%, patient they get relief from the pain after taking these analgesics. So yeah, one of the drug, like I would like to emphasize here, morphine, right? It is even mentioned in the Goodman-Gilman, which is considered as the Bible of the medicine, right? So morphine, is an opioid drug which was first discovered in 1804. It was mentioned that it's a God's own medicine, very hard to beat, and it's remained one of the most widely used drugs since its discovery. If we have such a wonderful analgesic available in the clinic, then why there is a need to pursue further on pain research? So the answer is here. So whatever opioid drugs which we have in the market, either they are natural or the synthetic opioid, they are suffering from the undesirable side effects and tolerance issues. Okay, so yeah, so non-specific activation of the mu-opioid receptor in the brain and the gastrointestinal tract by morphine and other clinically used opioid, they lead to severe side effects. For example, in central nervous system, they lead to sedation, dizziness, nausea, vomiting, respiratory depression, and physical dependence. So these are not like minor side effects. For example, when a opioid leads to respiratory depression, there are reports that thousands of patients, they die in not only United States but from all over the world due to overdose of the opioids because of the respiratory depression. And when the patient is on long-term opioid use, they get addicted to it. So doctors are always in dilemma, like what to give these patients, when these opioids are having such kind of toxicities. On peripheral nervous system, opioids lead to constipation, which is another major clinical complaint of opioid use. Then this is a report, from American Society, for Pain Management, which suggests that the opioid usage associated with the sedation and respiratory depression. At the same time, the opioid, when they are used for a longer period of time, the tolerance develop. Means if initially, for example, 5 mg per kg of morphine was effective in treating the pain, after some time, even 10 mg per kg of dose won't be able to produce the same analgesic effect. So they lose their efficacy over a period of time. So that is one of the reasons why opioids and opioid-like drugs for the treatment of neuropathic pain, they have been degraded from first line to second and third line of therapy in the past several years. Okay, now the question is that which we asked, when we are working on this project, can we develop some better therapies for the treatment of neuropathic pain, which will be devoid of these, all these toxicities. So in the light of these challenges, current efforts have focused on identifying new therapeutic targets that selectively and specifically modulate the opioid receptor signaling and function so as to achieve the analgesia without causing any kind of toxicity. Okay. So in light of this, we have decided to, explore one of the heteromers of the opioid. A lot of people are working in the field of opioid from past several years, but we had tried to, focus on the heteromers. And we all know that G protein coupled receptor can either form homomers or heteromers as well. Homomer we know, right? When two similar kind of receptor, they attach or work with each other, we call it homomer. For example, mu receptor, if they attach with each other, we call it homomer. But when different kind of opioid receptor or other category of receptor, they form the like join together, we call them heterodimer. For example, mu delta, or mu cannabinide, something like that, right? So we know that heteromers or heterodimers, they exhibit novel pharmacology such as altered ligand binding properties, G protein coupling, and trafficking that differs from that of homomers. There are several reports which support the idea that mu and delta opioid receptors may exist as heterodimer in the brain regions which are involved in the pain signaling. So the unique pharmacology of these heterodimers may represent a novel analgesic target. This is what we felt. So when we were going through the literature, we found that the role of mu delta heterodimer, specifically in peripheral opioid tolerance and peripheral pain mechanism, has not been well examined, in part because of lack of specific pharmacological tools. So now the reason why we decided to target the mu delta opioid receptor heterodimer, we thought that it is an attractive target for the inhibition neuropathic pain because we can target these heterodimers in the periphery itself, and it may provide a more potent and long-lasting inhibition of neuropathic pain. At the same time, it may produce less or no off-target mediated adverse effects. We can also avoid the tolerance and the addiction issues which are associated with opioid treatment. So, the aim of our study was to determine the effect of spinal nerve injury, which is one of the gold standard model of neuropathic pain, and the effect of repeated mu opioid receptor agonist administration on mu delta heterodimer expression in the DRG mu delta heterodimer targeting agonist, which is CYM510 compound in animal model of neuropathic pain. So this molecule was recently discovered only a few years back. So that was the reason why this field was, was yet unexplored in the past. And then we decided to dissect the cellular and molecular mechanisms which are involved in mu delta heterodimer activation mediated pain relief. So in our study, we have used the Sprout Dolly rats weighing from 200 to 300 grams. Then we have used the wild type mice. At the same time, we also use the mu opioid receptor knockout mice and the delta opioid receptor knockout mice. And we have used the spinal nerve ligation model, as I mentioned, L5 spinal nerve ligation model in rats. In mice, this L5 nerve is corresponding to the L4 spinal nerve. So that's why in mice we call it L4 spinal nerve ligation model. Okay. Then another surgery we performed in the animals is the intrathecal catheter implantation surgery, because we wanted to understand the role of spinal, heterodimer receptors in the, analgesia and pain. So we have implanted the catheter so that we can deliver the drug specifically to the spinal cord of the animals. Then we have used different molecules like CMY510, Dalda, which is another peripheral opioid agonist, morphine, which is a mu opioid agonist, and then we have performed behavior test, electrophysiology, and tissue immunofluorescence. So here, if you can see this in picture, what you see right now here on the left hand side, this is the spinal cord, okay, and different spinal nerves are coming out of the spinal cord, actually L3, L4, L5, L6. In the rat model of neuropathic pain, we ligate the L5 spinal nerve and we cut it to produce the long-lasting model of neuropathic pain. So this is the first set of data which we got. In this, we wanted to understand the effect of spinal nerve ligation surgery on mu delta heterodimer expression in the DRG neurons of the animals. So as you can see in the left-hand side from the immunohistochemistry data, like the top panel is about the L5 DRG neurons, which is the injured DRG, I would say, where we ligated and cut the nerve. And then L4 DRG is the DRG which is adjacent to the injured one, but it is uninjured, right? We have not done any injury in L4 now. So this is the control, and then SNL. Again, in case of L4, also control and SNL. So in control, we did not observe any kind of difference in the mu delta opioid heterodimers. But in case of, this hollow one, the white one is the L4 DRG and the black bar is the L5 DRG. So we found that, in case of L5 DRG, the L4 DRG neurons, there was significant increase in the mu delta opioid heterodimer, right? So here you can see the green fluorescence is because of the, mu opioid receptor, and the red fluorescence belongs to the mu delta opioid heterodimer. So when they merges together, they are producing the orange fluorescence. So after the spinal ligation surgery, we found that in the L5-DRG neuron, there was a decrease in this fluorescence, orange fluorescence, which clearly indicate that the opioid heterodimers, they are actually, decreasing in the, L5-DRG neurons, which are injured one. But in case of L4-DRG neurons, which are uninjured, actually this, heterodimers are increasing in his number. So that we feel is like a compensatory mechanism. What is decreasing in the L5-DRG neurons is increasing in the L4-DRG neurons. So that is a compensatory mechanism of the nature of the body, I would say, which try to protect the organism from the pain relief, I would say. Okay, and this is the data from the immunohistochemistry, and we were able to carry out this study with the help of Professor Lakshmi Devi, who is working in New York, one of the institute. And then we try to confirm this data by using the ELISA study. So by using ELISA also, we found that again in the L4-DRG neurons, there was an increase in mu delta heterodimer, while in the black bar you can see, there is a decrease in the mu delta heterodimers. And very interestingly, what we found that when we treated these animals with DALDA, which is a mu opioid receptor agonist, peripheral mu opioid receptor agonist, it doesn't cross the blood-brain barrier. This increase in mu delta heterodimer was surprisingly, increased a lot, both in the L4-DRG neurons and the L5-DRG neurons. So we were wondering like why it is happening. So then we performed some of the behavior studies to understand the effect of mu delta opioid receptor agonist, which is a CYM510 molecule. We wanted to know whether activating this heterodimer can produce the pain relief or not, because before that it was not reported. So we thought to check it. So we have used this molecule in 2 different doses, which is 0.2 mg per kg and 2 mg per kg. So on the left hand side, what you see is a worm-free hair test, which is a test for the measurement of mechanical allodynia in animals. So these are the hair-like structures of different intensities, and we try to poke the plantar region of the injured and the uninjured paw of the animals to see at what force animals will withdraw their paws, and try to record the force at which they are feeling pain. And on the right hand side, what you see is a Hargreaves apparatus, which was developed by the scientist Ken Hargreaves. And in this test, we use the light stimuli of specific intensity to stimulate the injured and uninjured paw of the animals to see at what time animals withdraw their paw. So this is very, very obvious. If the animals are suffering from pain, their paw withdrawal threshold in worm-free hair test and paw withdrawal latencies in Hargreaves test will be decreased. That means their pain threshold will get decreased and they will withdraw their paws much earlier as compared to the control animals. So this is exactly what we observed. This is the pre-SNL. Pre-SNL means pre-injury baseline, okay? In both cases, like panel A and panel B. So here animals were not injured. So this is the baseline, pre-SNL baseline. Then we did the SNL surgery in these animals. Then we found that after day 7 of the SNL surgery, the paw withdrawal threshold and also the paw withdrawal latency in case of panel B was significantly decreased. That means these animals are suffering from pain. Then again, we test the pre-drug baseline, that is before giving the drug treatment. And then we found that when we administer the CYM510 molecule, which is a mu delta heterodimer agonist, we found that at 0.2 mg per kg dose, there was no effect. That means 0.2 mg per kg dose was not able to affect the decreased pain threshold in these animals. But 2 mg per kg dose, the higher dose, the black circle, this dose was able to increase the paw withdrawal threshold and the paw withdrawal latency in these nerve injured animals. Okay. Then after that, we ran a dose dependent study where we wanted to see like what could be the effect of this molecule if we use it in a different doses. So then we decided to go for the 0.5, 0.1, 1.5 and 4 mg per kg doses. So we found that the results were consistent as observed in the previous study. Then we also did the Rotarod test, which is a very important test to find out whether this molecule has some kind of toxicity in the central nervous system or not, just like morphine-like drug. So fortunately, this molecule does not produce any kind of motor coordination in these animals. Okay. So now the next question, which we asked, whether this molecule, be working, if we give it under the condition of opioid tolerance, because that is one of the most, important clinical complication of opioid drug that develop tolerance over a period of time. So we have used the protocol of morphine tolerance, in which we give the morphine in a dose of 10 mg per kg every day, 2 times a day for 7 days. So what you see here is a power withdrawal threshold before injury, and then this is dropping down. That means after injury, and pre-D1 means that is before, on day 1 before giving drug, and then this is shooting up. Shooting up is indicating the effect of the drug, effect of the morphine actually. And then on the next day, day 2 means that is on day 2 before giving the morphine. So you can see every day, before, after giving the morphine, this is shooting up, which indicates that power withdrawal threshold is increasing and indicating that morphine is able to relieve the pain. But when the morphine is given repeatedly for 5, 6, 7 days, this analgesic effect of morphine is lost, which clearly indicate that morphine lost its efficacy after continuous day 7, injections. So then, this indicates that the tolerance has been developed. So we use the same animals actually to see whether this, because in one of our study we found that after giving the opioid treatment, the mu delta heterodimer expression were increasing. So we wanted to take the advantage of this increased heterodimer expression in our study. So we use this molecule, which is a heterodimer agonist, and wanted to see that whether it can relieve the pain under the opioid tolerance condition or not. So this is what you can see in the panel B. This is pre-tolerance condition, and then after that post-tolerance. So before the tolerance, it was very obvious, and we did this study before as well. We found that this molecule was able to inhibit the pain only at 2 mg per kg, but at 0.2 mg per kg, which is 10 times lower dose, was not effective. And then after the tolerance also, we found that this molecule was still effective in relieving the neuropathic pain, both in case of mechanical pain behavior and thermal pain behavior. But to our surprise, the dose, which was not effective in treating the thermal hyperalgesia before tolerance, you can see this, the panel C actually, the gray circle in the middle. So 0.2 mg per kg dose was not effective in relieving the thermal pain in these animals before the tolerance condition. But after the tolerance, when we are expecting that these heterodimers are more in number, even the 0.2 mg per kg, the lowest dose was still, able to, produce the pain relief. So this finding were very, exciting for our, project. So then we wanted to understand the another, dimension of the pain, which is ongoing pain, because there's a lot of debate, in the field of pain research, where people and scientists debate a lot to understand, what we are measuring in the animal in terms of mechanical and thermal hyperalgesia. Are they the true reflection of what human beings are feeling? So just to, address that query, recently, one of the professor in University of Arizona, in the last, I think 7-8 years, he developed, one, I would say the, technique, which is condition place preference, which was originally used for drug addiction, to see whether it can give a true reflection of the spontaneous ongoing pain in animals or not. So in this technique, what we generally do, we restrict the animal in different chamber, for example, chamber A versus chamber B. And in chamber A and chamber B, we provide the different visual cues and the different tactile cues to the animal. That means chamber A and chamber B are completely different from each other in terms of the visual cues and the tactile cues. You can see at the bottom, one chamber may have a groups, another chamber is completely plain. One chamber has horizontal lines, another chamber has vertical lines. So these kind of cues animals can understand. Now, if the animal is under pain, and if you're treating that animal with some analgesic drug which can relieve their pain, and restrict that animal into that chamber for a period of time, say for 30 minutes or 1 hour, depending upon the duration of action of that analgesic drug. So animal can associate that feeling of pain relief with its environment, which is very natural, right? So based on this concept, an animal can remember actually, the conditions under which the animal felt the pain relief actually. And on the other hand, in another chamber, we treat the animal with the vehicle, which does not produce any pain relief. And then in the post conditioning, we allow the animal to choose either of these chambers. So the principle of this technique is based on this, concept. Basically, animals will, spend more time in the chamber in which the animal was having the pain relief. So this can give a kind of indication whether the animals can get relief from spontaneous ongoing pain or not. So yeah, so in this test, we as I mentioned that in chamber we pair them with vehicle, and other we pair them with drug. So this is the difference score, which is calculated from the after subtraction the time spent in during preconditioning versus post conditioning. So the black bar clearly indicates that the time spent in CYM paired chamber was increased by the nerve injured animals. Okay. So this is in case of SNL animals which are nerve injured. When the same test was performed with the control animals which were not suffering from neuropathic pain, we found that these animals were not able to differentiate between the vehicle versus drug paired chamber. So this indicates that these animals cannot associate that feeling because they are not suffering from any kind of pain. Okay. So how much time do I have, Dr. Alok?
We have 10 minutes.
Okay, I will try to wrap up in time. Yeah. Okay. So now in the next part of the study, we wanted to understand, like after giving any, opioid-like drug, what is happening with the delta opioid receptor. So we have performed the, co-internalization receptor study in which we have used the HAC293 T cells. And in these cells, we have labeled the, mu opioid receptor with the green fluorescence HA. And we have labeled the delta opioid receptor with the MIC, which is red in color. So you can see in the B panel as well. So delta opioid receptors were tagged with the red color, and mu opioid receptor were tagged with the green color fluorescence. Then we had 4 different groups in this study. First was the control group. Second is the DAMGO, 5 macromole DAMGO. DAMGO is a agonist of the mu opioid receptor. Now third one is the 5 macromole DALDA, which is again a mu opioid receptor agonist, but it is peripherally acting because it cannot cross the blood-brain barrier. Now, fourth one is the 5 macromole CYM510 molecule, which is a mu delta opioid heterodimer agonist. So all these drugs are more or less associated with the opioid agonism, you can say. They are agonist of opioid or receptors, basically. So we found that when we activate the opioid receptor, either it is mu opioid receptor or mu delta opioid receptor heterodimer, this mu receptor activation is leading to the co-internalization of the delta opioid receptor as well. You can see in the control group where we have treated the animals with the vehicle, actually, the receptor like green fluorescence and the red fluorescence, it is mostly on the surface of the cell, HAC293 cells. But when the same cells were treated with DAMGO, DALDA, and CYM510, all this fluorescence is moving towards the center of the cells, which is indicating that there is increased internalization of the delta opioid receptor and mu opioid receptors once they are activated. Okay. So this is actually indicating their functional interaction with each other. Okay. Now the next question, we wanted to understand the role of, because we know that we have different pain fibers in our body, which which helps in the transmission of different kind of pain sensation. So for example, A delta fiber, these are myelinated fiber which are fast conducting and conduct at a speed of 20 meters per second, and the C fiber which are non-myelinated fiber and they are slow conducting, right? And there's one phenomena in the pain research which we call as Winder phenomena, which indicates increased excitability or you can say hyperexcitability of the neurons when the animals are neuropathic or when animals are suffering from chronic pain. Okay, so we wanted to understand the effect of this agonist CYM510 molecule on the different kind of pain fibers, like what are the pain fibers which it can affect. So you can see here like in the first, panel, we try to study the effect of this agonist on the A alpha and A beta component. And we found that, you can see the black circle and the white circle, they are running together, So which clearly indicate that this is white circle is pre-drug treatment, pre-CYM, and the black circle is post-CYM. Okay, so which clearly indicate that after the treatment with CYM molecule, there is no effect on the A alpha or A beta component. So this study was done in animals, anesthetized animals, and we have placed one stimulating electrode in the paws of the animals, and the recording electrode is placed in the lamina 2 of the spinal cord of the anesthetized animals. Okay. Now in the next panel, we have studied the effect of this molecule on the C component, and as you can see that after the treatment with CYM molecule, the C fiber response was decreased, as we are increasing the stimulation intensity. So that's clearly indicate that this molecule has an impact on C fiber activity. Then we also try to study the effect on wind of function, overall wind of function, and you can see that, as compared to white circle, the black line is running at the bottom. So this again indicate that the CYM molecule can actually decrease the overall wind of function. That means it can decrease the hyperexcitability of the neurons in the spinal cord of neuropathic animals. Okay. So then, again, we because we wanted to understand the contribution of different opioid receptor in the analgesia caused by CYM molecule. So we have used, mu opioid receptor knockout animals in this study. And as you can see in the panel A, when because in mice we can use different forces of 145 fibers, like low force versus high force. So you can see that in the wild type animal, which is white circle, and the knockout mu opioid receptor knockout animals, which is the black circle. So in the wild type animal, the drug, this is pre-SNL baseline, okay, then this is pre-drug baseline, and then this is 60 minutes after the drug treatment and 120 minutes post-drug treatment. So it clearly indicate that the wild type animals, they were still, able to show the, the percent povidor frequency was much lower. That means they are feeling less pain as compared to the knockout animals. Okay. So it clearly indicates that if you knock out the mu opioid receptor, the analgesic effect of this molecule will be lost. Okay. So yeah, so this was all about the, this study. I think I have finished in time. So this suggests that the span of injury, increases the mu delta heterodimers in the uninjured DRG neurons, and these heterodimers may be a potential therapeutic target for the treatment of not only neuropathic pain, but even under conditions of opioid tolerance. So this is what we recently published in Pain Journal, which is one of the good journal in our field. So yeah. And I would like to acknowledge my team, specifically, Professor Srinivasa Raja, who is Director of Pain Research in Johns Hopkins University, and my postdoc supervisor as well. And these are my students, who were really, great support, in performing some of the experiments, presented in this study. I would like to acknowledge Department of Pharmaceutical Engineering and Technology, IIT BHU Varanasi, for providing the facilities and infrastructure. I would also like to acknowledge my funding agencies, SERP, for providing the early career and the core research grant, and MHRD for providing the Spark research grant. So in the last, I would like to end up my presentation with a quote that anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. So learning should never end. Thank you. Thank you so much. I would be happy to answer any questions.
So thank you, Dr. Tiwari, for such an insightful journey of pain. So I think everybody might have, its lecture has been very informative for this new relevant topic. I see a question in the audience from Professor Swasti. So, ma'am, can you please?
Yes, can you hear me?
Good morning, ma'am. Yes, I can hear you.
Good morning. Dr. Vinod, very nice talk. And I want to stay young, so I'm learning again.
Thank you so much, madam.
And you actually started with a very beautiful concept about acute pain, that it is not actually something which is, we should actually appreciate that we are having some sort of acute pain, which is an indication. So I have actually couple of questions about the new the CYM thing you're working on. So what about because I see that in the last slide, because I think I have some internet issues, so I couldn't see it clearly, but you have shown something that it has effect in the regular mice but not in the knockout mice. So that is actually the only experiment you have done to rule out the off-target effect, or you have done something else to see that these are do not have off-target. So,
yeah, so this is the data you're talking about, right? Yeah.
Right.
So actually, this study was done to understand, the mechanism of action of this molecule, because we believe that this molecule is the activator of mu delta opioid receptor heterodimer. So we wanted to understand if we knock out the animals with mu opioid receptor, so definitely, there will not be any possibility of making a heterodimer when one receptor out of two is absent, right? So we wanted to understand if we knock down one receptor, whether this molecule will still have some efficacy or not. So this is just to, confirm the mechanism of action of this molecule. So in the absence of, mu opioid receptor, this molecule, has lost its efficacy. So that was the purpose.
And did you ever try to see that whether this also develops tolerance later on, like the opioid receptor?
Yes, that's a good question. Actually, that data is not here somehow, but yes, just like morphine, like a 7 days treatment twice a day, just like the opioid tolerance protocol, we did the same thing with this molecule as well. And to our surprise, we did not observe any kind of tolerance with this molecule. Fortunately, at least for a 7 days treatment protocol. But we don't know whether, if this treatment will be continued for like 14 days or 21 days in animals, what will happen. So that is something which we don't know.
Okay. And lastly, because I'm not working on neuropathic pain, but I'm just wondering, the parameters you have used to see the readout of whether they're having pain or not is both the behavioral parameters, like paired cage or the other one you have shown. But is there any way to get some objective data like stress hormones or something in these animals to see the response of the drug, or if they are having pain or not?
Of course, there are so many biomarkers of pain, I would say, and which, many people who are working in the field of pain, they do measure, such as substance P is there, which is, we call, substance P, and then CGRP is there. So there are a lot of other biomarkers. Then if somebody is working on some, like neurotransmitters as well, some key brain regions, reward circuitry, if somebody is working on role of reward circuitry in pain. So they are exploring the role of dopamine as well in that. So there are a lot of biomarkers, which can be investigated.
Okay, thank you. Excellent talk. Thank you.
Thank you, madam.
So I would, Dr. Alok also have a few questions.
Thank you, Dr. Vinod. It's very interesting, and pain is really very important topic, and in fact you are in the divine city Banaras, which also very matched to you, means pain as well as the city is also, lots of people are visit Banaras for if they feel pain, right? So very well matched. So that, but the pain is really very important aspect, neuropathic pain. And so I'm wondering if means this drug is tested in other model as well, means like diabetic neuropathy or something other model?
I don't think so, but I haven't seen the recent literature. But I think since last year, I can say that, this was the first report on neuropathic pain. But it would be interesting to see, if this molecule can have some, like effects in other model of, like pain. That would be interesting.
Right. Yeah. And so it's very interesting regarding your Delta and all the drug treatment, and we look forward for the further development. Thank you.
Thank you so much. It is my pleasure, to be here. And, again, thank you so much to Dr. Alok, for inviting me and for this, talk.
So since we are pressed with the time, so I will ask if there is any questions from the audience, so they can just post in the chat box. So, and with this, I would like to thank Professor Dr. Tiwari for their time and the presentation, and thank you very much. And have a
You can
good day.
feel, thank you so much, Dr. Santosh. I really appreciate it. And if students have any question, they can drop me on my email ID as well. Yeah, thank you.
Yeah, we will get back to them. Yeah.
Sure. Thanks.
So
Okay.
now, yeah, please.
Okay.
Now I would like to request Dr. Alok to please introduce our next speaker.
Okay, so our next speaker is Dr. Ashish Srivastava from IIT Kanpur. So let me introduce him. So Dr. Ashish is currently a DBT Wellcome Trust Fellow and working in Department of Biological Science and Bioengineering at the IIT Kanpur. And Dr. Srivastava completed his PhD from CSIR IITR in 2014, and then he moved to IIT Kanpur to carry out the postdoctoral research. So his research interest is focused on understanding the activation mechanism of protein coupled receptors, their downstream signaling, and modulation of their function. He is closely working with Professor Arun Kumar Sukla and is involved in generation of target-specific synthetic antibody fragments from phage display technology. In a very short time, Dr. Srivastava significantly contributed in publication in many international reputed journals such as Nature Communication, Nature Nanotechnology, Nature Structure and Molecular Biology, Cell Report, Cell, Journal of Biological Science, Science Advance, and many more and highly cited articles. So with this, let's hear Dr. Ashish. Dr. Ashish, please go ahead.
Okay, so Alok, am I audible?
Yes.
And my slides are visible to you,
Yes.
all of you?
Right, yeah,
Okay.
your slide is also visible. Yeah.
Okay, just wait. Okay, so first of all, I would like to thank Dr. Alok and the Department of Molecular Medicine at SGPGI for inviting me to talk about my research work, which I am pursuing since half a decade in IIT Kanpur. So the as the theme of this meeting was basically based on the antibody fragment or antibody therapies. So I am not basically the applied medical researcher, and basically we have touched these synthetic antibody fragments for our work. So I thought that it would be a very good idea to present in this meeting about some synthetic antibody fragments and their allosteric modulations of drug target using this antibody fragments technology. So since half a decade, I am working in the IIT Kanpur as a currently I am also an early career fellow from DBT Wellcome Trust India Alliance, and the primary focus of our research work is on the important class of cell surface receptors known as GPCRs or G protein coupled receptors, as you have heard in just last talk from BHU. So these GPCRs basically having 7 transmembrane structures. So these GPCRs also called as 7 transmembrane receptors. So these are the largest and class of the membrane proteins and cell surface receptors. Around 800 members have been identified in human genome. And out of these 800 members, like 200 to 250 are well known and characterized, while the remaining are still orphan receptors. So this provide a new researcher to like a big opportunity to work on different kind of receptor by without any scientific overlap. So these receptors basically involved in almost every physiological process in our body you can think of. So these and there are number of pharmaceutical drugs target these receptors, and it can be like you can think that like currently 40% of the prescribed drug target these GPCRs. So some of the examples like angiotensin blockers used to treat the blood pressure, and like histamine blockers used to treat the allergic reactions, and so on. The list is very long. So I have just kept few examples here. So now it is very important that to know about the fundamental mechanism and their activation mechanism about these receptors, like how they bind their signal, how they activate it, and how they mediate their signaling axis, and how they are regulated. So once the ligand of GPCR, or we can say agonist, binds to its receptor, the receptor get activated, and activated receptors recruit the G protein, which further then activated by GDP-GTP exchange and mediate the G protein signaling by generating a set of second messengers like cyclic AMP, IP3, and calcium ions. Similarly, the constitutive activation of G protein and their signaling might have the harmful effect to the cell, or we can say the deleterious effect to the cell homeostasis. So cells have devised a mechanism that regulate this G protein signaling. So by this way, a GRK, also known as G protein receptor kinases, comes in the way, and they phosphorylate the GPCR primarily on the C terminus of the receptor. This phosphorylated C terminus have the high affinity for a cytosolic effector protein known as beta arrestins. So once the beta arrestin binds to GPCR, it do not allow further G protein to bind to it, and by the steric hindrance process known as desensitization. Beta arrestin also scaffold protein family from endocytotic machinery like clathrin, AP2, and mediate their internalization, also known as receptor endocytosis. Beta arrestin also binds with the binds the E3 ubiquitin ligase that ubiquitinate the receptor beta arrestin complex and followed by the degradation of the receptor complex. Beta arrestin, as I have already discussed, that have the scaffolding ability. So it scaffold a number of like phosphatases and kinases and mediate their own signaling known as G protein independent and beta arrestin dependent signaling. So this is the new paradigm, and my today's talk basically focused on the regulation of receptor beta arrestin signaling axis using antibody approach. As we can see here that the spectrum of like beta arrestin mediated signaling is quite very large. So the majority of the beta arrestin functions in context of GPCR regulation and signaling are mediated primarily by their scaffolding ability, by scaffolding several interaction partners. So for example, like beta arrestin can scaffold, as I have said, that endoproteins or endocytotic machinery proteins like clathrin, adaptin, and mediate the internalizations. And also similarly, the beta arrestin also scaffold several kinases of MAP kinase family to mediate the beta arrestin dependent signaling. So now biochemical studies have suggested that beta-stin scaffold many of their interaction partners through non-overlapping interaction interface. So one can have a golden opportunity to selectively target the beta-stin interactions interface to selectively modulate the functional outcomes. For example, it is possible to selectively inhibit one function of the beta-stin by keeping the other function unaltered. There are several number of approaches to modulate the GPCR beta-stin signaling axis, which has been reported in literature. So these include bias ligand, pepdicins, and gene knockout siRNA. But collectively, all these reported approach for modulating GPCR beta-stin signaling has their drawbacks. So for example, bias ligand are those who preferentially activate the one signaling arm over the other. So for example, if we use the bias ligand, G protein bias ligand, it will allow only G protein signaling, but not allow the beta-stin signaling, and vice versa. If we use the beta-stin bias ligand, it will allow only beta-stin signaling, but not allow G protein signaling. So by using the bias ligand mediated modulation, it will completely ablate either G protein or either beta-stin complete mediated signaling. Similarly, the pepdicins are the small molecules that targeted at the intracellular side of the receptor. So these are membrane permeables and binds to intracellular side of the receptors. These pepdicins mediated modulation of GPCR beta-stin signaling leads to a signaling bias. Also, most conventional or we can say popular technique like gene knockout or siRNA mediated gene knockout strategy completely disrupt the beta-stin functions. So as I have said in my earlier slide, that beta-stin have their multiple interaction interface for different effector proteins, and these effector interaction interface are distinct from each other. So once we use the conventional techniques of the modulation of beta-stin function, it can ablate all these functions because the beta-stin expression and function is completely ablated. But the current approach, as I have said, the current approach completely ablate the beta-stin function. The selective blocking of these interaction interface will provide a better opportunity for selecting the disruption of specific beta-stin function, or we can say disruption or modulation of the beta-stin functions. So for the proof of the concept, we have used a previously reported synthetic antibody fragment in our lab. So this FAP30, which is referred to as FAP30 here. So this FAP30 is able to recognize active beta-stin 1 conformation, which is bound with the V2R phospholipid. This V2R phospholipid is derived from the prototypical vasopressin receptor C-terminus, and once it binds to the beta-stin, the receptor is activated, and this active conformation is recognized by the FAP30. So first we thought that we should confirm the selectivity of FAP30 to bind to the active conformation of beta-stin 1. So as you can see in this CoIP experiment, the FAP30 is able to recognize only active beta-stin 1 conformation, which is bound to the V2RPP, but it does not recognize the inactive beta-stin conformation. Next, we tested that whether this FAP30 binding to the beta-stin may interfere or may change the interaction of beta-stin with other interacting partners, which is clathrin and ARC here. So we find out that when we use this FAP30, the effect of FAP30 on beta-stin and arc interaction. So we found that it potentiate the arc activation. So we have used a FAB control here as a experimental control, because it do not interact, do not bind to the beta-arrestin. Similarly, surprisingly, when we tested the effect of FAB30 on clathrin beta-arrestin interaction, we found that there is no change of the beta-arrestin clathrin interaction, but only potentiate the beta-arrestin clathrin interaction, but beta-arrestin arc interactions. So as a proof of the principle, we have we thought that this allosteric modulation using the antibody fragment might be a useful and work very well with the system. So we thought that we should screen some more FABs against beta-arrestin to select and to see the effect on different beta-arrestin functional outcomes. So we hypothesized that selective targeting of the different interacting interface on beta-arrestin by antibody fragment might selectively modulate specific beta-arrestin mediated GPCR functions. So we have performed the selection of FAB from FAB libraries against a beta-arrestin 2. So let me talk about beta-arrestin, that there are two major isoforms of beta-arrestin, that is beta-arrestin 1 and beta-arrestin 2. So we have performed the selection of FAB against beta-arrestin 1, beta-arrestin 2, but here I am only focusing about the FAB which we have selected against beta-arrestin 2. So what we did, we first bite annihilated the beta-arrestin and immobilized on the streptavidin beads, and then incubated with the FAB libraries, which we have already reported. So once these FAB binds to its bound beta-arrestin 2, we washed the unbound FAB libraries, and then the specific binders were eluted and amplified, and then again bind to the immobilized target. So by after like 3 screening, we have finally eluted the specific binders of beta-arrestin 2 and challenged with the beta-arrestin 1, because in this case beta-arrestin 1, we are selecting the FAB against beta-arrestin 2 but not beta-arrestin 1. So we have done the negative selection with beta-arrestin 1 to eliminate the FABs which also have the specificity for beta-arrestin 1. So by this way we found that the FABs that are only specific for beta-arrestin 2. Next, after selection, around 24 clones we have isolated, we have selected and confirmed their binding specificity for beta-arrestin 2 in phase ELISA. And after confirming the specific binders, we have sequenced them, and unique clones on some unique clones having the unique sequence were expressed in E. coli and purified as a protein. So, and after purification as a protein, these FABs were further confirmed for their selectivity for beta-arrestin 2. So as you can see here in the right side, there are two FAB, that is FAB3 and FAB5, which were highly selective for beta-arrestin 2, but not binds with beta-arrestin 1. So we have further tested their interaction with beta-arrestin 2 in dose-dependent manner and confirm their specificity. Next, we found when we studied the effect of these FABs in the interaction of beta-arrestin with clathrin and ERK, then we found that surprisingly, out of these two Fabs, Fab5 have like inhibitory effect on the interaction of beta-stim 2 with clathrin. So we have taken a Fab control here which do not binds to beta-stim 2. And if you can see in the lower panel, the effect of this Fab5 was not significant in beta-stim 2 ERK activations. So these findings have like provided us an idea that it might be a very good candidate to see the effect of these Fab inside the cell for the endocytosis, because clathrin mediate the endocytosis function inside the cell. So for expressing these Fab inside the cell, it's quite very challenging because the cytoplasmic environment of these mammalian cells is reducing in nature, and the functional assembly of these Fab require a disulfide bond. So we express these Fab in the form of SCF5, where these heavy and light chain variable fragments were joined by a linker sequence. So once we clone this Fab5 and form this SCF5, we measured their specificity for beta-stim 2, because conversion from Fab5 to SCF5 may lose its selectivity. So we first confirmed their selectivity, and we found yes, this SCF5 is still able to bind specifically to beta-stim 2, but not beta-stim 1, as seen in this OIP and ELISA format. Then we see the effect of this Fab5 on beta-stim 2 clathrin and beta-stim 2 ERK interactions. So we again, for the Fab5, similar to Fab5, this SCF5 is able to inhibit the interaction interface of beta-stim 2 with clathrin, but not with the ERK, beta-stim 2 and ERK. Then once we confirm at the level of SCF5, we express these SCF5 inside the HEK293 cells as an antibody, and first we check confirm their expression, as you can see here in the lower panel in the lysate. So this is the SCF control, and this is the SCF5. So after, and then again we tested their functional selectivity for beta-stim 2 as an intrabody by using the co-immunoprecipitation assay, and you can see in this quantification that SCF control have as compared to SCF control, the SCF5 has a significant beta-stim 2 interactions. So before measuring the effect of this SCF5 as an antibody on the receptor endocytosis, it is a prerequisite condition that these SCF as an antibody will not affect the receptor beta-stim interaction. So in order to evaluate the effect of this antibody on receptor beta-stim interaction, we perform the confocal based experiment where we have taken a beta-stim 2 M-cherry, which is read in here, and SCF5 antibody with YFP tag, and then we have used this experiment with the receptor system, which is vasopressin receptor, which is a prototypical GPCR. So we express the receptor and beta-stim 2 and SCF antibody inside the cell, and after stimulation, like early time points in 5 minutes, when you can see this beta-stim is recruited to the plasma membrane of the cell, and the SCFP5 is also colocalized at the membrane. So it is it is now clear that this SCFE do not have any like effect on the receptor beta arrestin, because once the cells activated, receptor activated, beta arrestin go to the membrane and interact with the receptor. Similarly, we also confirm the effect of intrabody on receptor beta arrestin interaction by using this co-IP experiment. So you can see here that this SCFP5 do not have any like inhibitory effect on receptor beta arrestin interaction in any case. Before moving to the next slide, so let me talk about the GPCR endocytosis assay, which we have used in our lab. So we have used a cell-based ELISA for assessing the GPCR endocytosis. So for this, what we did, we overexpressed the receptor because our receptor is N-terminally flag tag. So once we stimulated the receptor get internalized by using beta arrestin dependent endocytosis. So at the surface, the number of receptor will be lower down, and this change in the receptor concentration at the surface will be plotted as a function of the time. So we have used this assay for measuring the endocytosis inside the HEK293 cells. So we analyzed the effect of intrabody 5 in V2R system. So we found a robust inhibition of the endocytosis in HEK2 for the V2R system in HEK293 cells, as you can see here. And we also corroborated these findings to for the in real-time system using the confocal based macroscopy approach. So again, here we have used the beta arrestin 2 mCherry, and the cells where the control SCFP control intrabody was overexpressed, the beta arrestin localization to the membrane was seen at the early time point, like here in 180 seconds. And in the later time points, these beta arrestin form a punctated structures like here and like here. But surprisingly, where the cells where we have overexpressed this SCFP5 intrabody, the beta arrestin goes to the membrane at the early time point after stimulation, but it do not form a punctated structure. So punctated structures here show like endocytosis. So it is clearly telling us that SCFP5 as an intrabody have an inhibitory effect on endocytosis. So as we know that beta arrestin have some unlike this endocytosis, beta arrestin also have their signaling mechanism. So it believed for the most of the GPCRs that this early time point ARC activation. So we have taken this ARC activation as a signaling readout for the beta arrestin mediated function here. So for most of the GPCR, early time point ARC activation is primarily mediated by G protein, and the later time point was mediated by specifically through beta arrestins. So we have tested the effect of SCFP5 in both early and late time point ARC activations. And you can see here that this SCFP5 intrabody has no overall significant effect on the ARC activation. We also tested the inhibitory effect or the modulatory effect of this SCFP5 for a number of different receptors. So for example, like beta 2AR, M2R, dopamine 1, 2, 3, and 4. So all these receptors follow the same pattern, like SCF5 inhibited the endocytosis in all these receptors, but does not change the ERK activation. So at last, we can conclude like interaction of beta-arrestin with their partners can be targeted selectively and modulate the allosterically using synthetic antibody fragments. Intrabody-based approach provide a unique handle to modulate the selected GPCR functions with potential therapeutics. The ability of SCF5 antibody to inhibit the endocytosis of so many GPCRs selectively provide novel experimental frameworks to fine-tune GPCR functions. So, for example, in case of nephrogenic diabetes, there is a mutation at R137H mutation is found in mice model, and this mutation corresponds to the constitutive endocytosis in that disease condition. So these kinds of studies will be provide therapeutic implications to design antibody fragment inhibitor to block the endocytosis or to reduce the endocytosis in that case. So, but of course, there should be lots of work needs to be done before designing such a therapeutics and optimization of this therapeutic candidate. Again, this experimental framework provide to fine-tune the further GPCR function and can be extended to other GPCR factors, but also provide for the other signaling system. So I am stopping my talk here, and I would like to acknowledge my lab mates and my mentor, basically Professor Arun Shukla, who is a senior fellow of DBT Wellcome Trust India Alliance and Embo Young investigator. And I would like to also acknowledge the funding source from IIT Kanpur and my DBT Wellcome Trust India Alliance Early Career Fellowship to support our research program. And I also would like to thank to all of you for your kind patience while this talk.
Thank you. Thank you, Dr. Assis, and very nice presentation. And undoubtedly, it's very important aspect for intrabody selection and the GPCR, which is the potential immunotherapeutic or cellular therapeutic approaches. I'm wondering from where you are using this human phage display library. Do you have it, or you are getting from some other?
So we have these FAB libraries basically are already reported. So these libraries we have bought from our collaborator who is situated in University of Toronto. So
okay.
They have generated different libraries like in the FAB format, in SCF format, in intrabody format. So depending on the need, we can they are already generating that, putting the diversity of into that to use more efficiently for the selection purpose.
Okay. And did you try these binders to any disease model? Means any kind of the infectious disease model or any kind of?
Yeah, so we have not basically tested in the disease model system. This is basically our initial work, which provide us a clue that it is possible to design an inhibitor or allosteric modulator against any GPCR functions. So the beauty of choosing or selecting these FABs for to target specific functions of any of the protein, but keeping other function unaltered, because as I have already said that using other conventional approaches completely ablate all the functions related to that protein. So these are basically interaction interface specific synthetic antibody fragments, So these allow only the function of the protein. These only change or modulate the function of the protein where they have generated from their interface.
Okay. Thank you. So let me see. Okay, so Dr. Santosh, do you have?
Yes.
Yeah, go ahead, please.
Thank you, Dr. Ashish, for such a nice, wonderful, nice presentation. I have one question related to your single chain antibody fragments. So the one you try to target the clathrin endocytosis. So was there any change in the affinity so that means your Fab antibody fragment as a single chain antibody fragment, like say, was getting more specific in terms of the affinity maturation?
Yes. So basically, when we have used this, when we converted the Fab into SFE format, we found that the affinity was like high as compared to Fab. This can be because just a small size of the SCFP or intrabody as compared to the Fab. And we have tested this, but whole idea was basically just not to picking all the Fab or SCFPs which binds specifically to beta-arrestin, but the idea was just to pick those Fabs which have basically the effect on any of the signaling functions related to beta-arrestin. So initially we have taken around 15 to 20 different Fabs and tested for their functional modulation. And based on that, we have chosen few, as you can, as I have discussed, that Fab3 and Fab5 was basically able to express inside the cell, but other were not able to express inside the cell. So our criteria was just to see those Fab or choose those Fab which have at least first thing which express inside the cell and have any modulatory effect for the beta-arrestin mediated function. So we have not seriously taken the affinity as a main property for choosing those Fabs.
So, and my the next question is means a kind of a, because you mentioned say this beta-2 arrestin complex is going to be one related. So does the initial signaling, the GPCR density, they may also eventually regulate the density of the beta arrestins, and which will affect the antibody targeting, means in terms of density and the effectiveness, or the domain organization of the membrane, so which will regulate the beta-arrestin function and the antibody targeting.
Sorry, Santosh, can you please repeat your question? Actually,
my question is the beta-arrestin complex means they have a role, they are going to stick at the membrane nanodomain structure. So does that domain organization means what is the rate of the domain organization by which the antibody targeting may affect, either in terms of the initial GPCR density or the domain the organization are going to be formed, which will eventually going to affect the downstream effectiveness of your antibody targeting?
So antibody targeting, as I have said, these antibodies are when expressed inside the cell, these antibody, or we can say intrabody, specifically first binds to the beta-arrestin molecule, and when receptor is phosphoryl agonist induced or ligand induced, it recruits beta-arrestin, and this antibody is targeted to the membrane along with the beta-arrestin and modulate the function of beta-arrestin mediated functions signaling. So I think I'm not clear that what exactly you are talking about, but the scenario is this.
So in terms of like say that because this domain aggregation may eventually means basically disturb the distribution of your beta arrestin molecule, and then the effectiveness of these nano antibody fragments may eventually or possibly may affect like say the, so that was a kind of a concern in terms of the effectiveness.
Okay, so let me see. Okay, so there are no questions. So thank you so much, Dr. Aziz. Very nice presentation. Thank you. So now I would like to request Dr. Loken. Dr. Loken, please go ahead for the vote of thanks.
Yeah. So thank you, Dr. Alok. Am I audible?
Yeah.
Yeah. So once again, thank you, Dr. Alok and Dr. Santosh for organizing this useful and very informative webinar. We had, great speakers from the area of infectious diseases and bioengineering, including the biotech industry sector, as well as from academia. It was really a pleasure to listen to them and to learn recent advancements in the role of immune response in disease regulation. So just to summarize the overall learning from this event by highlighting few of them, Dr. Sanjay Singh, which have presented the work yesterday, he was the CEO of Genova Pharmaceuticals from Pune. He shared his recent ventures of developing mRNA-based COVID vaccine, which is a kind of parallel to Moderna mRNA vaccine. And he shared some of the preliminary clinical trial data and initial findings of the effectiveness of this vaccine. According to his calculations, we may get an additional indigenously developed mRNA vaccine by the end of this year, which may aid to the ongoing vaccination program across the country. So the overall presentation was very excellent and contemporary to increase our knowledge about the ongoing COVID pandemic. Subsequently, Dr. Tripathi from IISc Bangalore, he touched upon some of the important indicators of COVID-19 infection, primarily related to SD100 genes and thyroidoxin molecules or proteins, which could be exploited to develop potential prognostic marker for COVID-19 infection. In terms of other infectious diseases, we had very good speakers in today's talk. Dr. Rahul Verma from INST Mohali, he shared his work on potential therapeutic targets or therapeutic approaches to overcome the multi-drug resistance in tuberculosis. He suggested that host defense peptides are effective against TB bacteria, and nanoformulation, including HDP, could be used for developing effective treatment for tuberculosis. Similarly, Dr. Vinod Tiwari from IIT BHU, he discussed his views on pain pathway and ways to regulate pain through his research work. He shared his interesting work on mu delta opioid heterodimer and its applicability to be used as a potential target for the treatment of neuropathic pain, as well as for the opioid tolerance. And finally, Dr. Ashish Srivastava from IIT Kanpur, he shared his research on the allosteric modulation of drug target using synthetic antibody fragments, which could be useful as a bioengineering part for developing therapeutic strategies for treating various diseases. All in all, the webinar helped us to improve our overall understanding about the immune response, which was the basic motto or basic objective of this webinar. And we learn about how these immune response works in healthy condition as well as disease condition. So we hope to organize such events more frequently in future to bring together academia, health and industry sector together on a single platform to increase our knowledge and sharing as well as for collaborations. So with this, I would like to thank our head of the department for encouraging us to organize such events. And also a special thanks to Dr. Alok and Dr. Santosh for inviting such excellent speakers. In addition to that, I would also like to thank participants for attending the webinar, for their time, for their patience. And I request them to give us feedback about this event. We would really appreciate if you can provide us some suggestions to improve us in future. You can send us your feedback at molmed.sgpgi@gmail.com. I have already posted this on the chat box. So you can email us, give your suggestions, feedback, whatever you like. And thank you once again, all of you, for your time, and have a great weekend. So thank you so much. Bye-bye.
Thank you. Thank you, Loken.
Thank you.
So with this, I close the session. Thank you all. Please take care. Thanks.
Thank you everyone.